Welcome everybody to this Ask the Expert on a Saturday afternoon, and a very sunny one, as you can see from mine and Palak's background. And I'm joined by Dr. Palak Trivedi today, 1 week following the EASL International Research Congress. So thank you very much for joining us, Palak, so quickly after that Congress. And we're really eager to hear all the news and updates from that particular conference. And just to give everyone a bit of background, Dr. Trivedi is consultant at the University Hospital Birmingham, also leads the UK-PSC Research National Research Network, and is on various international groups as well. So we're in very, very good hands. And let's get going. So welcome, Palak.
Thank you for having me.
I'm really grateful you're here. First of all, let's talk about the NorUrso trial, because that's one we've all been waiting for. There were some early results announced last weekend, weren't there? So can you give us a little
Yeah,
update about what we found out?
sure. So the EASL, the European Association for Study of the Liver, that's our biggest annual international liver meeting, and where we hear about cutting edge early preliminary results from all the research in the liver world. And it was nice because we had lots on PSC, lots on related conditions, which would also lead to translational outputs for PSC. The NUC5 or NorUrso phase 3 trial, just a bit of background for those people who aren't aware. As many of you know, there is not a single licensed medical therapy or any medical therapy proven to slow PSC progression. And we've been clamoring for something positive in the sphere for a while. When we do clinical trials, we have to go through phases, generally phase 1, 2, 3, before a drug can enter the market. And then we have a phase 4 program, which is after the drug's been on the market, we then have to audit those outcomes. But we need to get to a phase 3 trial and a phase 3 trial to be positive before we can even start to talk to regulators and get market access. So the NUC5 trial was a phase 3 program following on from the successful phase 2 program of a compound called NorUrso deoxycholic acid. Many of you would have heard of urso deoxycholic acid. That's a bile acid which has been shown to reduce the acidity of bile when you take it by mouth. It also reduces some of the immune attack on your biliary epithelial cells, the cells that line your bile ducts. But it's not been shown to have significant benefit compared to no treatment at all in people with PSC. Many of you may still take it because it does lower/improve blood tests in some of you. And if you tolerate it, we continue that going. But overall, it doesn't cause a benefit. The NorUrso compound is an agent which, a bit like urso deoxycholic acid alone, it's a synthetic bile acid. But what happens is that we snip the side chain off it. So all the benefits that we get from urso, rather than them going from the bile ducts and then, like all bile acids do, go down to your bowel and then get passed out in stool, NorUrso has its effects, circulated between the liver and the bile duct. So that's where all the effects are maximized. So you get a much more potent benefit within the bile ducts. The phase 3 trial sought to do two things. First of all, could it slow down disease progression as confirmed by a liver biopsy? Are people able to stay in a single disease state or maintain their disease state or even improve their disease state, defined collectively as non-progression in liver disease stage? Secondly, the composite of that outcome of the trial was, can they improve liver biochemical markers, specifically something called ALP, alkaline phosphatase, to below 1.5 times the upper limit of normal? And that was the main readout. And that was over a 2-year period. It's important to know that 2-year period is the first main readout and what the regulators asked for as an initial first win. It's a bit like saying, if you are at home and you're trying to make some, let's take a simple item like pizza. I'm aware that not everybody may be able to tolerate that, but if you're saying cheese in whatever variety, sauce, and the dough are the core ingredients, that's what the regulators asked for. Can you make the core ingredients of a successful PSC trial? The other toppings to make it appetizing to all and appealable to all is still going to be coming out of this particular trial, because the study is going to continue, and it has continued for 4 years for a second readout, and then up to 6 years for the final readout, at least for the initial trial outcome. So this is the first set of results, and hopefully the regulators will see them as positively as I do, as we do in the community. Now, when it comes to the actual PSC, NorUrso trial, if I'm allowed to share my screen here, I can just share some graphs from the presentation that was there. So can you see this this window?
Yes, I can. It's
Yeah.
not in presenter mode.
Oh, that's okay. Don't worry. So I'm sharing this from my browser because I'm only able to show it in sort of a PDF form at the
And
moment.
it might be worth just also saying all the different ways we're calling NorUrso now, because it's got a new kind of,
Yes.
like it's got
Yeah.
a new name and a new acronym.
Yes, so I think NorUrso is still. I'm just trying to think if I can hide this site. Yeah, there we go. So NorUrso is the abbreviated version. NCA is an even shorter version. So I may refer to it as NCA or NorUrso for the purposes of today. This is the primary outcome. So normalization of partial normalization to below 1.5 times the upper limit of normal and no worsening of, this is a stage, there are many ways to stage liver disease. This is the stage that they used. Now you can see here, people in the placebo group, i.e. who received a dummy pill for 2 years, 4% of them in that particular trial had attained did not progress, and similarly improved their liver bloods without us doing anything to. So, and that is what we call a placebo effect.
And that's a bit like that's how PSC goes anyway, isn't it? It's up and down, up and down.
From a blood test point of view, yes. Sometimes people's bloods can go upwards, sometimes they can go down. It does fluctuate like a wave, and it's whether you can get that wave to below a flooding level, just for an analogy purpose. And in this trial, that flooding level was defined as 1.5 times the upper limit of normal, plus non-progression in liver fibrosis. Now you can see when we look at that composite, 15% of people who took the active compound at this dosage attained that. So it's a significant difference between the two. Just over 3 times as many people attained that outcome. Now, you may look at it and say, well, 15%, it's not that much, in terms of a proportion of people who participated, and compared to 4, yes, it's a bigger difference. It's important to then go down to the nitty-gritty of what that actually means in a particular trial. Remember, we are looking at 2 things: an ALP reduction below 1.5 times upper limit of normal and no worsening on a liver biopsy. When we do a clinical trial like this, it's important to also recognize it depends on how many people continued into that trial. For this trial to happen, everybody had to commit who took part into having a liver biopsy at the start of the study, at the 2-year mark, and for thereafter the 4-year mark and 6-year mark, which I won't go into any further. This trial started recruiting before the COVID pandemic and before the Russia-Ukraine war, and it was a pan-European study. So there were 2 big life events that happened when it comes to this. So there were some people who would have come out of the trial either for economic reasons, either because of health reasons not related to PSC, but because of the COVID pandemic. And that also applies to the industry colleagues who led this trial. There were certain decisions made. For example, if there were people or trial sites in Russia and other places that, I'm not going to go into the politics here, but there were some decisions that were made regarding, sort of dropout from this particular study. So when we look at people who followed the protocol strictly, i.e. they had a biopsy at the start, blood test at the start, blood test throughout the trial, and a biopsy at the end, they completed everything without fail, rather than the overall population who started, the numbers change. We can see 6.6% of people in placebo versus 18% of people in the active treatment. And when we look at people without any missing values whatsoever, it's just over 20% of people versus just over 5% of people. So 4 times as many people met the primary outcome measure in the study of not progressing on liver biopsy at 2 years, plus lowering their liver biochemistry to that that set threshold. So when you look at everybody who had completed values, then sort of the difference becomes a lot more stark. So 20%, that's 1 in 5. So 1 in 5 people did not progress on a liver biopsy and lowered their liver biochemistry in the active treatment group. This is at 2 years. We hope to see bigger differences at the 4-year and 6 years, because as I said on the video that some of you may have seen on PSC Support that Martine and I did when we were at the meeting, you don't have PSC for just 1 to 2 years. Many people have it for years and decades longer. So it's important to see if people can sustain those sort of that level of disease stage, and whether more people can meet it thereafter. I'm not going to go through all the slides in detail, but they looked at other liver disease stages as well, not just that Ludwig stage that I mentioned. You can look at people who are on URSO versus not on URSO, and this is where the biggest difference is. If you don't take URSO, then the NorUrso compound appears to work even better. So almost up to 25% versus 0% of people are sort of on URSO met that outcome. So the benefit seems to be maximized in this trial group. I'm not saying URSO versus non-URSO, that's not what the study is designed to look at, but at least in this trial population, the greatest benefit was seen in people who are not taking URSO deoxycholic acid alongside NorUrso.
Alec, sorry to interrupt you. Do you think that they would, well, when the final analysis comes, we'll be able to see whether people taking URSO already had some benefit, like we're bringing some benefit to the party, if that makes sense?
Sure.
And
I mean, yeah, I don't think it's in the slide set, but it was discussed at the meeting, so I'm allowed to mention that. I must mention that there is some trial data that I won't be able to discuss or share with you today because I'm bound by certain medical legal confidentiality disclosures, but that some of that was discussed at the actual liver meeting following the presentation. There was no real difference from what I can tell from the preliminary readout between people going into the trial who were on versus not on URSO, in the sense that people who were taking URSO versus not taking URSO, they looked the same. So they were at the same level of disease stage going in. So
yeah.
I can't, now what we don't know is when they started URSO, whenever that may have been before the trial, what they were at beforehand. That information we don't have, but certainly going into the trial, they were very, very similar between the two groups. So when they entered the trial, there was no real difference. When the trial was all said and done, those without taking URSO appeared to have more of a benefit. There is some biological and mechanistic rationale here to sort of in terms of the science, that yes, if you have URSO plus NorUrso, the NorUrso may not work well. That's mechanistic biological data. And I'm not saying everyone should stop URSO. This, NorUrso is not available, going to be available overnight or next week, and it's going to take some time. And I'm sure that may be some of the questions that people will ask. But at the moment, it appears that the greatest benefit appears to be those people not taking URSO deoxycholic acid.
Thank you.
Yeah, so I'll stop sharing those slides there, but that's sort of a very quick sort of roundup of the first readout of the NorUrso deoxycholic acid phase 3 trial that was presented last week.
So when Professor Trauner did his presentation, he described it as remarkable. And although it is only 15 or 20%, whichever way you look at it, that's still really good for this group of people. It's amazing for them.
So if from my point of view, this is not a narrative. This is factual data. If 1 in 5 people over 2 years slow or stop their disease progression, that is amazing, at least in my mind. And I don't know what the 4-year and 6-year data will be. And I'm hopeful, I'm optimistic that the difference will rise from that 20% and 1 in 5 people to greater numbers. I can't fathom to sort of estimate what that would be, but if that difference grows and you say, actually, what we're seeing is that, yes, they may have started to progress, but then things start to come down a bit and they get back to what their baseline was. If we start to see people in that placebo group who had some stability at 2 years just because that's the way that their disease was, if they have then started to progress even further, but those on NorUrso maintain, or slow down their condition, then that's again sort of something important. So this is a very early 2-year look. And most importantly, I'm not saying that NorUrso is going to be the treatment for absolutely everybody, but if it is something that we can frame other clinical trials of a similar ilk in future, it gives us a template to work on. So it's very encouraging to me.
Do you think at some point we'll be able to identify or predict who's going to respond to NorUrso?
Yeah, I think so. Absolutely. Yeah, I think so. And I certainly do believe that we would be able to, find out. So one of the things that, is often mentioned sometimes is around different types of PSC. Some people would have presented as autoimmune hepatitis. They then sort of evolved to develop PSC predominant. I don't believe that overlap syndrome is a thing. I don't believe you could have both things. That just doesn't happen. But we do have people who are at that transition point or have some features of autoimmune hepatitis. And so they were allowed to take part if they were on stable medications of dosages going in. So some of those people who had who may have had that label before were allowed entry. The subgroup analysis hasn't been done yet, but that's just one example where we are trying to see whether in subgroups of individuals, whether they would still benefit the same way as the overall whole, beyond the URSO, non-URSO group, and beyond how advanced people were when they went in. There's not, those subgroup analyses are not yet available publicly.
So, and I was distracted a little bit reading the questions then, but one of the questions, so people can vote on these questions. If you ask your questions in the Q&A box and there's a little thumbs up like sign, you can click on that and that will move, the ones with the most votes will move to the top of our list. And there's one here that just says, were the participants PSC only or did any have overlap with AMH? And
yeah.
so I'll click that as done. Okay, so the next question is, and this came up when you were talking about the Ludwig, the histology, the liver biopsy stages not getting worse. So could this lead to an improvement in beading?
Yeah. So they were not systematically capturing start and off treatment or end of treatment MRI scans. There are a subgroup who underwent that, but it wasn't mandatory for taking part in this trial. So we don't have that data yet.
And you would do you sometimes see alkaline phosphatase have any relationship to the amount of beading?
Not really. I mean, I've got some people who I look after that have got very widespread beading. I can't see a normal bile duct at all, and they've got normal alkaline phosphatase values. So I don't see a very strong. I mean, there must be some association, but it's not very strong.
Yeah. Okay. Thank you. This next question. Oh, hang on. It's not putting the ones with the most votes at the top. We'll have to search for them.
Okay.
So here was one with 3 votes. So in best case, when might NorUrso become available?
So in best case, I think it would be next year in 2026.
I mean, that's incredible, isn't it? And we have a bit of work to do if we want to be able to get that available to patients. That's really exciting. Okay, so next question I can see on here, and it's got some 2 extra votes, is what were the results for the other 4 out of 5 people? Did they have improvements but not quite up to targets they'd set? That's a good question, isn't it?
That's very good. So absolutely. So if I'm allowed to share again, I can probably just, I mean, it's not going to show it in the data in the same way, but I can certainly give some insight. So is that okay? Can you see it still?
Yeah, that's good. Changes in liver enzymes.
Yeah. So just as an example, so the upper limit of normal for alkaline phosphatase in our Birmingham laboratory is about between 110 and 130, depending on the age and sex you are. Now you can see here, so 1.5 times the upper limit of normal. I'll let people work that out, but the central laboratory that did those readings would have a slightly similar, but a very close upper limit of normal. Now you can see here that the black circles are those who took NorUrso, the white circles or lollipops are the ones who took placebo, and you can see that here is alkaline phosphatase value, and there are other liver biochemical values here. As a group, the vast majority, if not all people, lowered their alkaline phosphatase pretty rapidly, certainly by 3 months, 12 weeks. That was sustained during the course of the 2-year observation period we're reporting on. So most people did experience a reduction in alkaline phosphatase values. It just didn't go to that 1.5 times the upper limit of normal readout. So and that was part of, and that's certainly something that we need to we need to talk about, is the fact that they would have stabilized their liver biopsy and improved liver biochemistry, but not normalized it or not attained a value that's as low as that threshold, is that something that's that's still meaningful? The other
Mm.
type of data I just wanted to show, so these are slightly complicated diagrams called Sankey plots, and what they show is movement depending on the stage of liver disease that somebody is. I'm just trying to sort of get these the right way around. Yeah, let's do it. We'll do it this way around. So these are the different stages. So stage one is very minimal, very little changes in the liver. Stage four is very advanced changes sort of in the liver, and stage 2 and 3 are in between. So you want people to be closer towards the top of these graphs. Now what we are looking for is that if you look at the progression over the course of time, you can see that people who are in stage 1, stage 2, stage 3, and you can't obviously progress if you're stage 4. I mean, on a liver biopsy, numerically, you can't do that. 25% of people who are stage 2 they had progressed. 12.7% of people in stage 3 had progressed. The numbers are much greater in those who took placebo. So you can see 44.5% progressed if they were in stage 2, and 26.7% if progressed if they were in stage 3. So there are some people who received the drug who still did progress as a liver disease stage. I mean, the stage 1 is a very small number. We didn't have that many people who had very early stage, PSC who took part, because now if we look at the improvements in a similar vein, you can see that this is just showing it for stage 3, because I mean it just gets a bit too busy if we show all the percentages. But up to approximately 42% of people in stage 3 improved to stage 2. This is not looking at biochemistry at all. This is just on the liver biopsy over the course of time, and that's compared to 20% of people who improved on stage 3, or who were stage 3 to start with, over time. So there are just as I'm not answering the question directly because I can't tell you for each and every single one of those 4 or 5 people, but most people attained some improvement either in biochemistry and or liver histology, but just not to those pre-specified thresholds that were determining the primary outcome.
And the biopsies, it was one biopsy at the beginning, another biopsy after 2 years.
Yes, that's what was reported here. Yeah.
And then there are, for the people carrying on that open label, will have biopsies again at 2 years. Do you know?
Yes, that's correct. So there is in a trial like this, which we call a double-blind trial, i.e., the investigator and the person receiving therapy or placebo. None of us know what you're taking until the whole trial is finished, and then we can do what we call unblind ourselves to know what's happening. The only people who know that are a computer and some of the statisticians in the trial, not responsible for the analysis, but responsible for knowing how much medication is left and counting the pills and all that. The 2-year double-blind period then carries on to another 2-year double-blind period, so up to 4 years of being double-blind. Now, I don't know whether the same people at the start who are on therapy are going to be retained on therapy for that time period. We don't know that yet. After that 4-year total, 2 + 2 years, there is an open label extension, which is for a further 2 years, so up to 6 years. And there are, and NorUrso also continues to be studied in other PSC trial programs, specifically in people with very advanced disease, only for those people who had a blood change. So there are now spin-off studies that are carrying on, which will carry on in parallel, even if the drug becomes available commercially.
I thought it was very interesting how the alkaline phosphatase graphs that you showed, they showed this suddenly, it went down 12 weeks, so 3 months, the alkaline phosphatase came down and then it appeared to stabilize.
Yes.
But we don't know, because the biopsies are 2 years apart, we don't know was that damage, any damage, we don't know what, if anything, happened in the first 12 weeks. So I know that some people had reversal of their fibrosis.
Yes, that's right.
Did that happen in the first 12 weeks, or does that happen slowly over a long period of time? Does it carry on? That's what I'm trying, that question. Do you know what I'm trying to ask you?
Yeah, no, I understand. So just if I understood correctly, because the biopsies were only done at baseline and 2 years, we didn't do biopsies in between. We don't know how early that improvement occurs. No, you're absolutely right. because we didn't do biopsies throughout the trial. It was just done at the beginning and end at 2 years, and it will be done again at 4 years and again at 6 years. So it will be done.
Wait and see.
Yeah.
And it's not fair to put people through the same number of biopsies as blood tests, is it? That we don't
Yes,
want to
yeah.
have that
Biopsies
every-
are invasive, and it's important just to sort of recognize that. I mean, one good thing. I mean, Birmingham. I mean, I'm very proud of where I work, and I was very proud that Birmingham were a lead recruiter. Well, lead recruiter for for the NorUrso trial. So thank you for everybody who took part and everybody who expressed interest in the UK to do it. And it's only with your participation that we were able to deliver a study like this.
Yeah, there's some incredible people out there pioneering, because we would not have it, would we, without them?
Yeah.
Another question, and it's about quality of life. Was there any patient feedback on how they felt during the trial, please?
Yes, there was. So most people, I mean, just they would say that they would feel better. There was some quality of life assessments collected more systematically than just asking them, particularly with reference to fatigue, itching, and generalized quality of life in terms of what we call a chronic liver disease questionnaire. We did not see any significant differences in the way people were feeling in this particular trial, and that over a 2-year period. I think it's important to note that most people who took part in this study did not have significant itching, significant fatigue, i.e. very high values. That wasn't, the trial wasn't designed to look at that, but it did capture those things. So again, in the subgroup analyses of people who took part that did have the extremes of symptom burden, that sub-analysis is yet to come.
Thank you. And I remember seeing on our forums that some people felt that they were feeling better, whether they were on placebo or active drug, I don't know. That happens sometimes in trials, doesn't it, as well?
And some people who took part in the trial, when they stopped taking the study drug, i.e. they're not continuing in the later phases, they do report feeling less well, and after coming out of it. Now, it's difficult to know whether that was the drug, whether the fact that they felt more reassured and more monitored than they normally would. It's difficult to know that, but at the moment we don't have any evidence to say this will help improve quality of life. I'm not saying it won't, I'm not saying it will. We just need to do some more work on the data in various subgroups, because if you already feel okay, or if you already feel, say, yes, maybe I'm not as good as I was 10 years ago, but I'm getting on with life and it's not impacting my quality of life, and you're taking part in this trial, it may make no difference. But if you have very severe symptoms and you were taking the drug and you felt better, that subgroup of people we haven't done yet managed to break down the analyses yet.
Do they already set in advance which questionnaires or tools they're going to use to measure the symptoms? Because I know there are some, like PSC partners in America are developing some symptom specific tools. Could they ever be included in this sort of analysis, or would that have to have been agreed at the beginning?
It has to be agreed at the beginning for this particular type, for any trial really. So you have to agree what tools you're going to use at the beginning, because if you start the trial and then a new tool comes along that is everybody feels is the best overall impression of how they're feeling, the people who started the trial right at the beginning, we wouldn't have their baseline data because that tool wouldn't have been around or accepted then. So, excuse me, we can build in things as the trial goes on, but if we don't notice a difference, we won't know, because if it's only being measured in a subgroup of people. So I know as part of those people taking part in the Fargo trial, there are some people who feel much better in it, and they feel better as part of the trial. Now, I don't know whether they're receiving placebo or active fecal transplantation as part of Fargo, but some people feel a lot better in it. But as the trial has gone on, we don't know whether new tools will come apart. There have been some that have already been developed, and it's how do you incorporate them? Should you incorporate them in the middle when something comes along?
And you're still recruiting for that one, aren't you? Just a quick plug.
And we are still recruiting, so please take part if people sort of want to. We presented some highlights as to how the trials are going at the European Liver Meeting. We presented our vancomycin trial results as well there. So it was a meeting that was there was a lot of PSC activity, and then there was another PSC trial that presented positive results at a phase 2 level, but positive nonetheless, called ELMWOOD, which is a drug called elafibranor, which we have currently available, and we use that to treat another liver disease called PBC. But that was a positive phase 2 trial in PSC that was also presented at the same meeting as the NorUrso trial was.
That's really good, isn't it, to have one coming up in the background that's phase 2, because like you said at the beginning, one particular drug might not deal with everything it needs to deal with for PSC, so there could be other drugs that can add to the effect.
Yes, exactly. And I think that choice of words is ideal, because they add to the effect bit. There might be some people who respond completely to NorUrso, and that's all they need. There might be some people who respond to NorUrso partially, i.e. their condition slows down but still progresses, and you may need another compound like elafibranor or FMT or something, vancomycin or something to then get them down to an even better level. So individualizing care based on their responses or lack of responses, or the magnitude of responses, is definitely the way that we personalize medicine moving forward. We do the same thing with inflammatory bowel disease. We do the same thing with high blood pressure, diabetes. Chronic conditions require individualized care, and evidence base needs to be generated in a proper systematic way. And whilst everyone's in a hurry to get new treatments for PSC, myself included, we can't rush things and get ahead of ourselves and over market beyond what the data shows currently.
And that's a frustrating thing for us, but we understand as patients we want the drugs to be safe and effective, but also we want them as soon as possible. But there's so much involved, isn't there, in making drugs available to patients even after good trial results. There's a lot of work that goes into getting them
Yes, exactly.
available.
So the URSO, I mean, URSO is different to NorUrso, but when URSO was first used to treat a different liver condition called PBC, and it became available for that, people started giving it for PSC. Liver blood tests got better in a proportion. That's what the early phase trials showed, and everybody thought that URSO deoxycholic acid was the panacea for treatment for PSC. It was only when the phase 3 trials were completed that we realized that people who got very high doses of URSO in the PSC trials, despite having a much greater improvement in their liver blood tests, they actually did worse over the course of time. Their liver disease progressed despite their bloods getting better. So that's why we need to do clinical trials, or phase 3 trials, because if we rush and had just accepted URSO, high dose URSO as a treatment for PSC, we'd have lots of people, more people in fact than we currently do, whose liver condition would progress, more cancers, more liver transplants, more and nobody wants that.
No, they don't. And we might come back to that, because one of the days or the day before EASL, we were at a meeting discussing trial design. But first, we've got 25 questions to get through. There's quite a lot. So first we'll have a look at these, and if there's time at the end, maybe we can talk about some of those interesting suggestions that have been made. Okay, so did all the trial participants in the NorUrso study have IBD?
No, they didn't. So not everybody in the in the NorUrso trial had inflammatory bowel disease. There are some individuals who, sorry, let me rephrase that. Some trials which do require that. It was about 60% in the placebo group and about 67% of people in the NorUrso treated group. So roughly 2/3 of people had inflammatory bowel disease at study entry. Of course, we know some people can develop IBD after their PSC diagnosis, and there are some people who developed it in the trial as well.
Yeah. Thank you. This is not a question, it's a statement. PSC Info Poland sends greetings from Poland, and I didn't know about those guys, so I have to reach out to them. Thank you for your support and dedication. So you're giving our community in Poland great help as well. So thank you, Dr.
Very keen to work with them. Please reach out.
Yeah, definitely. Next question. My PSC is stable and bloods are excellent, but the MRC continues to show mildly worsening strictures, but at a very slow pace. I don't have IBD, but would someone like me be a candidate for NorUrso? I'd love to try something to slow down my PSC. Thanks for the superb update.
Yeah, sure. So it's a very interesting question for the, and I'm sorry to hear about what your, the anxiety that this may be causing with these, with the stricturing. In the NorUrso trial, the entry criteria were you had to have an elevated alkaline phosphatase value above that 1.5 times upper limit of normal at entry. You had to have when you go in. Now, I'm hoping the drug would be approved by the European and British regulators. I genuinely do not know whether they will mandate people to have abnormal liver blood tests in order for them to take part to receive that compound. I genuinely don't know.
Mm.
And we do have those restrictions in some of the other compounds we use in other liver diseases. And if we want to start, if we have features that the condition is worsening on, say, an MRI scan or a FibroScan or something to that effect, but the liver bloods would not allow you to take part within label, we then have to apply for special permissions to use it. And some of that may involve paying for the drug rather than it being funded through routine NHS means in order to get it. But I can't see why this person wouldn't benefit, because the main benefits that we see are on liver, biopsy. And it's so I can't, I don't know whether you would be eligible to receive it once it's available, but I certainly think you would be a good candidate to try it.
Yeah, thank you. Okay, I've just reordered. I've worked out how to order these questions now.
Okay.
Given the link between PSC and IBD, were similar improvements seen in the responders' IBD symptoms, or was IBD not looked at as part of this study?
So IBD activity was captured, but akin to the previous question, one of the specified entry criteria was that the IBD activity had to be quiescent, had to be calm at entry below a certain threshold. And at least in the opinion of the doctor who was recruiting that individual to the trial, it was anticipated that the IBD activity would remain at that particular level going into the study. Similarly, it was anticipated that they would not need to have any ERCPs or bile duct dilatations for a certain period of time. So it did not recruit people with very active IBD. I must mention, though, that there was a very interesting study again, it wasn't in the trial, but in parallel, looking at NorUrso from a biological point of view as to what it does to the bowel in animal studies and so on. And it does show that there are signals to indicate that it increases the amount of what we call T lymphocytes, T cells within the bowel, which are responsible at calming down inflammation. So there may be some effects, but it was not looked at in people with very active colitis.
Feel like we have to do some work to make sure everybody can get this drug if it's carries on with positive results, I think. Quick question here. What's the difference between URSO and NorUrso chemically?
Yeah, so chemically, it lacks a particular side chain. I'm trying to think if I've got a side by side. I don't have it in this deck, but I can probably find it while we're talking. But in short, it has a truncated side chain. So as a result of it, most of it undergoes what we call entero, i.e., so it undergoes colohepatic shuntings. Colo being the bile ducts, hepatic meaning the liver. So I can show you that image because I've got that here. So if I was and I can probably find differences if people are interested in the chemical structure. I can find that, but you can see this okay?
Yeah, that looks good.
Yeah, okay. So this is the NorUrso or NCA molecule, and as you can see here, it's an engineered derivative resistant to amidation. So it goes from the hepatocytes, your main liver cells, into the bile ducts, and then it recirculates, rather than URSO, which will go into the bile ducts, into the bowel, and then be recirculated from the bowel. Some of it does get to the bowel, but that's not where all the recirculation goes. Whatever goes to the bowel just comes out. So it's important just to notice that difference. But I will try and find something regarding chemical structure, because I do have slides on that. I just didn't have them prepared for today, but I do have a separate slide deck for that.
Good, thank you. That'll be interesting to see. What this person's asked, were inverse vaccines discussed? This is something that has been circulating, that was in the news recently, and I didn't see anything.
No, I don't believe so. No, I couldn't see anything at the meeting that were around inverse vaccines for PSC.
I did email the author of the paper that was published on this, that everybody's talking about online, and I've not heard anything back yet, but
Okay.
Fascinating for us.
Yes, yeah, absolutely.
Do you have any information on plans to bring NorUrso to the US?
It's not a decision up to me, I'm afraid. The US, the way it works in the US is historically, not all drugs, but most or many medications, they need to be trialed in the US before they can be available to people in the US. I suspect it may get to Canada before it gets to the US, because but the honest answer is I don't know. It really depends if there is a commercial company there that wishes to bring it, because Dr. Falk Pharma, which manufacture NorUrso, they don't have a they don't operate in the US. So I don't know is the answer. I'm hoping that it sort of that we can and do that.
Yeah, and the patient groups, PSC partners in America, PSC partners in Canada are active and will advocate for it to be brought over there for sure. Okay, I'm going to ask this question in a little bit of a different way, so it's not so personal. Somebody's son's got PSC, but they've not had a liver appointment for over a year. How could he be allowed to be offered this drug in the future? And that, assuming it can be prescribed to people.
So how you might, so it would be during your gastroenterology or liver appointment. That's when they would get it. I mean, if you don't have an appointment for over a year, I would certainly contact the secretary or the department that you're being looked after, because generally speaking, even if you've got mild PSC, at least our practice here is to see some people at least once a year if they've got PSC, and that's irrespective of whether they've got inflammatory bowel disease or not. But it would be via your PSC doctor, either your gastroenterologist or your hepatologist.
Yeah, and regardless if you've been to appointments or not, I suppose.
Yeah,
you're a patient, and if you go to your appointment, you'll be prescribed it if you're suitable.
yes, exactly.
You won't be penalised because you weren't there.
Yeah,
Okay.
exactly.
Next, let me just
quickly just share my screen. So I've got this.
You found it.
I've got one slide, yeah. But this is taken from a medical student presentation, so it doesn't project particularly well, but it was scanned in from one of one of the students' thesis. But you can see here, this is URSO, and this is the chemical structure of URSO, and you can have a look at NorUrso. So they remove this part of the molecule. That's
Wow.
yeah. So that's sort of the chemical difference.
Something so small can make such a big difference.
Yeah.
Is amazing.
Yeah.
And how well, we won't go into that, but I mean, how could somebody think of what needed to be done, to which bit to take off or add on?
Yeah, I mean, the molecule was first developed about 20 or just over 20 years ago in a lab in, I think, in Graz or in Vienna, one of the two main places in Austria. And yeah, and it's taken that long from discovery to outcome. The NorUrso phase 2 trial completed in 20 or read out at least in 2017, but I think opened in 2015. So it took about 10-11 years to get to that stage.
Yeah, I remember looking back on some PSC Support old newsletters, and one from 2010 where they asked Roger Chapman about what was going on with this new URSO, and I think it had just completed phase 1.
Yeah,
So it has been a long time coming, but they've carried on and they've not stopped and they've had some
yeah.
results.
I mean, yeah, if we didn't have COVID and the wars that we've had, I mean, I didn't even mention Israel Palestine again, a big impact on this.
Yeah.
Because there's lots of people with PSC in Israel. I think the trial would have read out a lot sooner, but the world gets in the way of these things sometimes.
Yeah, and they carried on despite all of those obstacles and the people on the trial. Okay, next question. What determines what stage of PSC you have? And is this treatment suitable for all stages?
Yeah. So I would say what determines, I wasn't sure whether they meant what biologically determines whether PSC progresses or not, or whether they mean how do we determine it from a medical point of view, how do we determine what stage you are? I think it may be the latter, but
Yeah, I
yeah,
think it is.
yeah. So in terms of determining what stage you are, um, in this particular trial, it was determined by liver biopsy. Now, liver biopsy is not performed as a routine standard in clinical practice. It is very much used for trials and for research purposes, unless we have doubt about your diagnosis. Um, so that's how we determine it. I forgot to mention that in this trial, it was people with large duct PSC that took part, i.e., they had an abnormal MRI. It wasn't people who had only changes on a liver biopsy. You have to have changes on an MRI or an ERCP to be diagnosed with PSC for the purposes of this study. You can't just have a normal MRI scan and have it only detected on liver biopsy. But liver biopsy is how they determine it in this particular study. In terms of can people with all stages have it? Yes, they did allow people in, provided they have what we call compensated disease. So that means not individuals with ascites, so abdominal fluid, not people who've had what we call variceal bleeding, not people on a liver transplant list, not people who still need repeated ERCPs to take part within the study, or if they had strictures that what we call dominant strictures that need intervention that hadn't yet been intervened on, that you had to, those things. So there were some restrictions, but they did recruit people very early, all the way through to people with cirrhosis, provided their liver function was to an adequate degree. They did exclude people who were very jaundiced, so a bilirubin that was roughly 4 times the upper limit of normal. So they were, they were excluded. People who had significant kidney failure or kidney dysfunction, and if people were still taking steroids or certain immunosuppressive drugs and biologics for inflammatory bowel disease at entry, if they needed to be started on those therapies during the trial, of course they could continue in the trial if those medications were warranted. And they also excluded people who have other liver diseases that might be contributory, for example, fatty liver disease, alcohol excess, and so on and so forth.
And that they were to make sure the trial was well designed, presumably.
Because if you have, say if you have another cause of your liver injury, I mean, I'm just using alcohol as an example. I'm not saying that's the only cause, but you know, if you've got PSC hitting your liver with one hand and you've got another liver disease with the other hand, and things progress, you won't know which of those two things are the main drivers of it in a study like this. So it was mainly to try to get some sort of homogeneity or some sort of likeness for people who took part inside the study.
So it can we say, so thinking about something like bezafibrate, that doesn't tend to get given to people who've got advanced disease or cirrhosis, am I right? And that's because of the way that drug works. Would would that be the case for NorUrso?
No, so I think that I mean, people who were within the criteria, even if they had, say, a bilirubin that was 3.5 times the upper limit of normal, they could still take part. People who had cirrhosis could still take part.
Yeah.
So it's only those people who had very advanced liver disease, to the point where they had ascites, they had jaundice above that threshold that I mentioned, they had what we call variceal bleeding or encephalopathy, that brain confusional state that we sometimes see with people on the liver transplant list. It was just those people who could not take part in the study, and not because of safety. It's just because when you've got to that stage, it's biologically it's less likely that a medicine like this would be of benefit. I'm not saying it won't. Those studies haven't been done in people with very advanced liver disease.
Thank you. And I guess what I was getting at was, okay, it was tested in a certain group of people, but actually looking forward when we're prescribing it, hopefully, we're aiming for everybody to be able to take it. So, for example, if you've got small duct PSC, just because you weren't allowed in the trial, our goal is to make it so that that is available to you.
Yes, if there is evidence that it helps those people, yes.
Yeah.
So we may disagree on that last bit, only because as yet we don't have the data that in people with small duct PSC it would be of benefit. I think if they have small duct PSC and they've got inflammatory bowel disease, which we know is a cofactor, then yes, if there is a certain degree of fibrosis on the biopsy, then yes. But at the moment, that's a bit of speculation. We don't know whether it would benefit that group or not.
Fair enough. I need to ask though.
Yeah, absolutely. Yeah.
So we've got 8 minutes left, and we've still got 25 questions, and we've already gone through quite a few. So let's try a few quick fire ones. So the first one I think was asked actually after you talked about it. Any improvements in gut symptoms? You mentioned that wasn't.
Yeah, I mean, there wasn't any overall any signal for that, but that's because most people didn't have active inflammatory bowel disease at the time of entry.
Good. My itching stopped after taking URSO. Does NorUrso give the same relief? Again.
Yeah, so we don't have data that it does. And overall, for everybody who took part in the trial, there was no difference at itching at the start and end. But most people who took part in the trial did not have significant untreated itch. We are waiting sub-analysis of that group at the top, who, a bit like this individual, had very severe itching, to see whether in that subgroup there was a difference. At the moment, we don't yet have those answers.
Okay, thank you. And the next question is an anonymous one, and it says the main symptoms of PSC, itching and depression and fatigue, that really affect quality of life.
Yeah.
Is this not impacted? And I think the answer is the same. We don't know yet.
Yes, most people didn't have severe symptoms, but in the group with severe symptoms, we are awaiting that sub-analysis to delve down in that proportion of individuals, whether there was a big difference.
Yeah, good. They're good questions, aren't they? These. Let's crack on.
I've just seen one which I thought I'd just clarify. So when earlier on there was a question about liver disease stage and how you stage PSC, I mentioned that in the trial they did stage it by liver biopsy. In day-to-day practice, we stage it with many things such as a FibroScan, MRI, blood tests, and your symptoms. So we use those 4 main things to determine where individuals' PSC is at. We don't routinely biopsy people outside of clinical trials. So if people are saying, why have I not had a liver biopsy? That is normal, that is common, that is in fact standard. We don't anticipate people should have a liver biopsy unless they're taking part in studies like this. I just thought I'd just clarify that.
Yeah, thank you. Next question, what are the side effects of NorUrso?
So we didn't see any major side effects from NorUrso compared to people who were taking who were in the placebo group. I'm just trying to see if so if I can share again this particular deck, just give me a moment. So if I share that, so this is just this is what we call a treatment emergent adverse events. So any adverse events, and you can see, I mean, by design, twice as many people got the active treatment versus placebo in this study. If you look at the overall adverse events, the percentages are the important bits here, and you've got the actual numbers, and you've got the total number here between the two. So when we call something as an adverse event, it can be anything such as a cold, anything such as I've got less hair when I exited the trial than when I started. So absolutely everything is captured in a clinical trial. So it is normal, common to see treatment, to see the vast majority of people who take part in any form of trial like this to have something. If you didn't, they'll think, you know, you're a robot, or, you know, you're not doing the trial properly. So you can see when we look at, you know, when we look at the commonest things such as diarrhea, so there's, you know, 16% versus people who took placebo, 16.7%, no real difference. I mentioned that that COVID emerged midway through the trial. The proportion of people's, yes, numerically there was slightly more people. It wasn't sort of, you know, much different. Nasopharyngitis, which is you know, like nasal cold type symptoms, you can see the percentage differences here. Headaches, slightly less people. Itching was asked for. 34% developed itching, or based on itching got worse, versus 30.2%. Small percentage differences. Anything that was determined by the local investigator related to study drug, there was 47% versus 41.7 or 42%. Drug discontinuation, more people discontinued on placebo because they felt the symptoms that they were experiencing in that 2-year time frame were due to what they were taking, but they were actually taking placebo, versus 6% of people who took it. I must mention that any of these common adverse events, people would have continued, unless they wanted to, they would have continued the drug and the symptoms would have got better despite continuing it on the trial. So it was not felt that they weren't necessarily related. But if the investigator, if the local investigator in the trial site felt they were related, these are the percentages that sort of were put in. But reassuringly, the discontinuation rates were not that high. Serious adverse events, sort of again, whether it's related or not related, is below here. You know, 1.9% versus 2.1%. You know, 4 people out of 206, 2 people out of 96. They're very, you know, sort of very, very small numbers indeed. One person sadly sort of did pass away during the trial, not thought to be related to the drug, but it was completely independent. And I've already alluded to the time frame and other global circumstances that were surrounding this trial. So it'll be unfair for me, it'll be unethical for me to sort of go into more detail, but it was not thought to be related to the drug as to why that person passed away, at least from what I'm told, from what was presented at the meeting.
One person also asked, and I've lost the question completely, if anyone went on to need a transplant that was on the trial, the NorUrso trial.
Yes, there would have been some. I can't give you the numbers for it, but I can tell you that the numbers, because we had that volume of people and some with cirrhosis, and there were some people who took part in the trial who did go on to need a transplant in both arms of the study. But I can't tell you the exact numbers because I'm not allowed to tell you the exact numbers. But it is not a worrying difference where more people in NorUrso versus placebo. But I can't tell you the numbers today. But there are some, small number, very small, but yeah.
Thank you. Someone else has asked if you can be put on this trial, and we perhaps clarify that.
So the trial is complete now. So you can't. So it completed recruitment in 2022. So you can't take part in that trial. The people who took part in that trial have carried on to that 4-year and 6-year time point, but you can't be put into this trial now because it finished 3 years ago, I'm afraid.
Thank you. So it takes such a long time. Now we've got 1 minute left. So I think I'll just add a comment from PSC Partners Canada. They are watching. So hi, Mary. And she says she really appreciates your direct responses to the patient questions.
Cool.
And they're probably going to be coming their way as well. And they've got a patient event next week.
Yeah, and I'm happy to do something similar for them if they wish. Yeah.
Fabulous. I'm sure they'll appreciate that very much.
Yeah.
So I'm sorry, everybody, that we haven't managed to get through all the questions, and I hope we have covered most things that are coming up. And thank you, Dr. Trivedi, for giving up your Saturday afternoon for us so soon after being away from home for a week. We really, really appreciate that. And as always, we'd like you to come back and answer more at another point.
Yes, thank you very much.
Thank you so much. Thank you, everyone, for your great questions. And we'll close it on time. Thanks then, everyone.
Thank you.
Bye-bye.